This is Schizoid and Schizotypal Personality Disorders by Ryan Forrest. In our abnormal psychology textbook by Bridley and Daffin Jr., we learn that personality disorders have four major components that separate them from other categories: distorted thinking patterns, problematic emotional responses, over or under-regulated impulse control, and interpersonal difficulties. In the DSM-5, the personality disorder category has three clusters. Each cluster has differentiating factors that separate it from the other two. We find schizoid personality disorder and schizotypal personality disorder in the cluster A, along with paranoid personality disorder. This report will only be covering those two personality disorders. The A cluster of personality disorders is considered the odd or eccentric cluster. Common to schizoid and schizotypal personality disorder is social awkwardness and social withdrawal. All cluster A individuals, including paranoid personality disorder, have difficulty forming and keeping close relationships, but the cause for discord in paranoid personality individuals is often the paranoia itself, while schizoid and schizotypal personality disorder folks don't seek engagement or closeness with others. It's similar to schizophrenia in this way, but the major difference between these two and schizophrenia is that schizophrenia symptoms are more extensive or impactful to daily functioning. I'll cover some of the challenges in later slides, but schizophrenia spectrum disorders include psychosis symptoms and delusions, where schizoid and schizotypal personality disorders don't. Often, schizoid and schizotypal personality disorder individuals have family members diagnosed with schizophrenia. Schizoid and schizotypal personality disorders are not in the schizophrenia spectrum. According to an article by Bateman and Gunderson at the Mayo Clinic posted in Psychology Today in 2015, these two disorders present with lifelong patterns of behavior, while disorders found in the schizophrenia spectrum category typically have an onset in early adulthood. Also, schizoid and schizotypal personality disorder individuals are generally unaware of their condition, and because of that, they aren't under the same distress. Schizophrenia individuals present with hallucinations, paranoia, or suffer from distorted thinking or speech. These symptoms are more common in the schizophrenia spectrum and usually cause greater distress. The DSM-5 calls schizoid personality disorder a pervasive pattern of detachment from social relationships and restricted range of emotions in interpersonal settings, beginning in early adulthood and present in a variety of contexts. At least four of the below criteria have to be met in order to diagnose with schizoid personality disorder. The individual doesn't enjoy close relationships, including with family members. The individual generally opts to be alone rather than with others. Doesn't usually have interest in sexual activities with others. Doesn't usually have activities that they enjoy participating in. Doesn't usually have anyone with whom they can confide in other than core family members. Doesn't need or want personal feedback, either positive or negative, and appears cold, indifferent, and detached in their emotions. Schizoid personality disorder is also homogeneous, so it can't be diagnosed along with other personality disorders or spectrum disorders such as schizophrenia or autism. And, as always, these symptoms can't be explainable due to other medical circumstances. Schizotypal personality disorder is a continuous pattern of social deficits that individuals who suffer from it don't necessarily want or even recognize as a problem. These individuals also exhibit odd, eccentric, or peculiar characteristics. These signs usually show up by early adulthood and can present in a variety of ways. At least 5 of the following criteria have to be met to diagnose for schizotypal personality disorder. I changed the order of the criteria listed in the DSM to fit my slide presentation, but they're all here. Paranoid or suspicious ideation, ideas of reference, A belief that a specific ideas of reference is a belief that specific occurrences around an individual are directly related to them when they're not necessarily. Misperception, experiences of self, including body image distortions. No close friends or confidants other than family members. Excessive anxiety. A high amount of social anxiety that doesn't decrease normally over time or experience, and this anxiety usually comes from a paranoia rather than self-judgments. Strange or abnormal beliefs about mystical thinkings that don't line up with their cultural norms, so maybe superstitious or beliefs in extra scientific understandings like telepathy or clairvoyance. Odd thinking and speech. Examples might be overly vague or overly specific communication. Inappropriate or constricted affect or emotions or expressions. Odd, eccentric, or peculiar behavior. The DSM-5 shows an increased risk for those who have relatives with schizophrenia or schizotypal personality disorder in both schizoid and schizotypal personality disorder. Some studies suggest that men are more likely to be diagnosed with schizoid personality disorder than females. Others show that there is no significant difference. There is a slight increase in schizotypal personality disorder risk for males. Many cultures place more spiritual significance on mysticism and superstitious thinking, as you might recall from my earlier slide. Either of these can be criteria for diagnosing schizotypal personality disorder, so caution needs to be taken to consider what's normal and abnormal for individuals within their own culture. There isn't a whole lot as far as risk factors in the DSM for either of these disorders, but some studies have shown increased risk for schizoid in individuals with past childhood abuse and for schizotypal in individuals with a history of being victimized by peers. According to the DSM-5, the estimated prevalence of schizoid personality disorder, based on a comorbidity survey, in 2007 was 4.9. In that same study, the estimated prevalence of schizotypal personality disorder was found to be 3.3. In the National Epidemiological Survey on Alcohol and Related Conditions, they found the prevalence of schizoid personality disorder to be 3.1 in 2004. In 2009, a similar study was conducted from the same organization to find a 3.9% prevalence in schizotypal personality disorder. In 2018, median prevalence of at least 5 surveys was at 0.6% for schizotypal personality disorder and 1.3% median prevalence for schizoid personality disorder. As some of the greatest challenges for individuals with personal disorders is learning to live with and form working relationships with those in their environment, it's likely that someone in their circle of influence may first suggest seeking clinical help. For schizotypal personality disorder, cognitive behavioral therapy may be indicated alongside supporting structures from family and friends. For schizoid individuals, talk therapy with a professional may be indicated, and eventually group therapy may offer a safer environment to slowly introduce new healthy relationships. There are no indicated medications for schizoid or for schizotypal personality disorder currently, and no FDA-approved medications for schizoid personality disorder. Medications may be indicated to treat symptoms of depression or anxiety as needed depending on the severity.